Good evening, everyone. I'm Jackie Dominguez, one of ALF's National Senior Directors of Engagement, and I'd like to be the first to welcome you to the academic debates presented by Rocky Mountain. This educational program is brought to you by the Rocky Mountain Planning Committee, Dr. James Burton, Dr. John Goff, and Dr. Michael Narkowitz. We are excited about our topics, proud of our teams, grateful to our sponsors, and honored to have such an outstanding panel of judges alongside our esteemed moderator. We are grateful that you would take time out of your busy schedule to join us and hope you enjoy the evening. This academic debate is being delivered on the Zoom webinar platform and will be recorded. During the presentations, if you have a question, please hover your mouse over the bottom of your screen and click on Q&A. Then simply type your question into the Q&A box. For all other comments and to cheer on your favorite team, please use the Q&A box as well. Again, please note that this program is being recorded and will be available on ALF's YouTube channel for future viewing. As I mentioned earlier, we're extremely grateful for our sponsors. Our national sponsors are supporting the debates across the nation and include national gold sponsors, AbbVie and ASI, and national silver sponsor, Salix. Our national bronze sponsors are Alexion, Mallinckrodt, and Pfizer. Let's hear what our national gold and silver sponsors have to say.
Right now, millions of patients are suffering with GI disorders such as overt hepatic encephalopathy, irritable bowel syndrome, chronic idiopathic constipation, opioid-induced constipation, bowel preparation, and ulcerative colitis. At Salix, we have kept up with these unmet needs for more than 30 years by providing an industry-leading portfolio of high-quality products that address these conditions. Through our dedicated and innovative R&D team, we're also exploring potential new scientific breakthroughs. And we remain committed to important healthcare provider investments in education, charitable grants, and sponsorships. We will continue to invest millions of dollars in patient education and do our best to broaden access to Salix medications. Because our mission to improve the care for GI patients continues today. For us, there is no finish line.
We are so appreciative of our sponsors' support. We encourage you to thank them when you visit with them. Without their support, we would not be able to continue to fulfill our mission. I wanted to give another shout out to those who tirelessly dedicate themselves to the liver patients and caregivers, the Rocky Mountain Medical Advisory Council. They meet quarterly to work with the ALF to provide education for healthcare providers and patients, addressing the unique needs of those in the Rocky Mountain area. Look at this impressive list of liver experts. We're so honored to have them guide us as we fulfill our mission. A special thank you to our Rocky Mountain Chair, Dr. Michael Narkowitz. Before I introduce our moderator, I wanted to acknowledge our technology team, Barb Potter and Karen Irwin, and ALF's national team, Nancy Clemens and Erica Bachter. We couldn't do this without their expertise. And now it's time to turn the program over to someone who really doesn't need an introduction. He is highly regarded by the members of the Rocky Mountain medical community and beyond. Please join me in welcoming our moderator for tonight, Dr. Michael Narkowitz of Children's Hospital, Colorado. He is a professor of pediatrics in the section of pediatric gastroenterology, hepatology, and nutrition at the University of Colorado Denver School of Medicine in Aurora. He serves as a physician executive for Children's Hospital, Colorado. Dr. Narkowitz received his AB from Dartmouth College, his MD from the University of Vermont, and did his residency and fellowship at the University of Colorado. His major areas of clinical interest are pediatric liver disease, viral hepatitis, acute liver failure, and cystic fibrosis liver disease. He has research grant funding from the NIH and the Cystic Fibrosis Foundation, and industry funding for viral hepatitis clinical trials for hepatitis B and C in children. Tonight, Dr. Narkowitz will be saying a few words about the history and format of the debates, including our interactive audience poll. He'll explain how you can help support the mission of the American Liver Foundation, how you can promote the debates through our social media, and introduce our esteemed panel of judges for tonight's debates. Dr. Narkowitz.
Thank you, Jackie. I want to welcome everyone to the first Rocky Mountain chapter of the American Liver Foundation academic debate. The academic debates have been sponsored by the American Liver Foundation for 18 years, and they've been recognized for excellence and are a signature program of the ALF and the AASLD. The topic and teams for tonight's debate were selected by members of our Rocky Mountain Advisory Committee, and tonight it's my pleasure to present two debate teams. Each team features two fellows in gastroenterology mentored by senior clinician educators with liver expertise. Each team will debate an opposing side to tonight's topic. I think it's worth noting that while we only have one topic tonight, the positions were assigned randomly. Presenters will be sharing a PowerPoint presentation, and they have 8 minutes to present. After both sides have presented their positions, there will be a 5-minute rebuttal without slides. Heads up, each speaker is going to be closely timed. If at any time a presenter or rebutter exceeds their time limit, the microphone's going to be muted by our timekeeper. At the end of all of this, there'll be a brief Q&A by our panel of judges, and that will last for 5 minutes. I want to point out there's no right or wrong answer on this topic. However, there may be very strong opinions for one side or the other, which can often lead to a lively debate. We provided the criteria to the team members to focus on creating professional and well-researched PowerPoint presentations. They've practiced and refined their rebuttal skills through thorough research of their assigned topic and position. And they're prepared to show how quickly they can think on their feet during Q&A. To include an interactive component for our audience, I want to mention there'll be a couple of polling questions throughout the evening. We're hoping that you'll take a minute to respond to these polling questions. Of course, always feel free to cheer on your favorite team, posting messages in the Q&A. The chat function's not available, but the Q&A is there for your use. We'd like to acknowledge the hard work of our presenting teams, their mentors, and express our appreciation to our sponsors, judges, timekeepers, tech team, and all of the volunteers. Importantly, I'd like to thank all of you, the participants who are joining us this evening. At the conclusion of the evening, all the team members will be recognized for their outstanding work, presentations, and dedication to the liver community. As many of you know, the American Liver Foundation this year is celebrating its 45th year. Despite the pandemic, and due to the resilience of the ALF staff, stakeholders, leadership, and our partners, we stand strong in our commitment to provide resources to the liver community. Resources far exceed the excellent literature and information on the website. The ALF continues to provide many virtual opportunities, and I hope you participated in some of those, that unite the liver community. Events such as virtual walks, our marathon, Cuisine for a Cause, and patient and healthcare professional education programs. There's been a dramatic increase in callers to the ALF helpline and visits to the website, demonstrating the relevancy of the information and services that are provided. We take a leadership role in advocating on behalf of millions of Americans living with liver disease and maintain a reputation serving as the patient voice for individuals with liver disease. I encourage everyone to use social media throughout the evening. Follow the debate's Twitter feed, which is @ALF Debates, shown on the screen. Now, before I introduce the topic and team members, it's my privilege to introduce the outstanding panel of judges. These judges will join us at the conclusion of the debate, ask thought-provoking questions, and help us decide on who presented the best debate. The outstanding panel of judges include Dr. Julia Booster. She's at Children's Hospital Colorado. Dr. Booster is a pediatric transplant hepatologist in the Digestive Health Institute at Children's Hospital Colorado. She is an assistant professor of pediatrics at the University of Colorado School of Medicine. Next is Dr. John Goff. Dr. Goff practices at Rocky Mountain Gastroenterology. He is a clinical professor of medicine at the University of Colorado School of Medicine, and he's a member of the National American Liver Foundation Medical Advisory Board, and in 2012 received the Rocky Mountain chapter of the ALF Peak of Excellence Award. Our last distinguished judge is Dr. Shikha Sundaram. Dr. Sundaram is also a pediatric transplant hepatologist in the Digestive Health Institute at Children's Hospital Colorado. She serves as the medical director of the pediatric liver transplant program at Children's, and she is an associate professor of pediatrics at the University of Colorado School of Medicine. The key clinical question for this debate is whether or not there's a clinical benefit for using beta blockers in individuals with decompensated cirrhosis. As a reminder, the pro presentation will have 8 minutes, the con presentation will have 8 minutes, then a rebuttal for 5, another rebuttal for 5, and a Q&A session for 5 minutes. So let's get to the case. This is the case set up to debate the use of beta blockers in decompensated cirrhosis. The particular case that's going to be discussed by our panel will be a 52-year-old female with a history of esophageal variceal bleed last year who has refractory ascites, now requiring paracentesis every 1 to 2 weeks. She has no history of spontaneous bacterial peritonitis. She's undergone serial endoscopic band ligation, and at last look, she had just grade 1 varices. She has a past medical history of diabetes treated with insulin. She also has a history of encephalopathy treated with lactulose and rifaximin. On examination, her blood pressure is 110/50. Her heart rate is 84. She has moderate ascites and lower extremity edema. Her laboratory studies show a bilirubin of 4.1, creatinine of 1.2, and her MELD sodium is 20. She asks you after the exam if she should take a non-selective beta blocker. She's been reading a little bit about this. The role of non-selective beta blockers, abbreviated NSBB, in the management of patients with end-stage liver disease seems to remain controversial. The use of beta blockers is effective as both primary and secondary prophylaxis for variceal hemorrhage, though there is some recent data suggesting that these may be harmful in patients with decompensated cirrhosis, particularly with refractory ascites, spontaneous bacterial peritonitis, or hypotension. This has led to the so-called window hypothesis that proposes there's a good physiologic window during which cirrhotic patients benefit from beta blockers. And given our clinical data, the optimal role and timing for beta blockade in cirrhotics with ascites remains unclear. Thus, the pro debate is going by the University of Colorado School of Medicine is going to take the position that the window, which we talked about here, is open, and that in cirrhotic patients with ascites, the clinical benefits of beta blockade outweigh the risks and should be prescribed. The con argument taken by Parkview Medical Center will be that the window is closed, that in cirrhotic patients with ascites, the clinical risks of beta blockade outweigh the benefits and should not be prescribed. Now, before we start this debate, we're going to start with a poll. Based on the case study I just read, do you feel that in cirrhotic patients with ascites, the clinical benefit of beta blockade outweighs the risks and should be prescribed? Yes or no? So here we have the opinion going in is about pretty evenly split, maybe slightly favoring yes. So with that, I'll introduce the debate teams. Presenting the position that the window is open is the University of Colorado School of Medicine. The mentors are Michael Kriss and John Norvell. The fellows presenting for the University of Colorado School of Medicine are Dr. Kathleen Yan and Dr. John Rice. Presenting the con, the window is closed, from Parkview Medical Center. The mentor is Dr. Charles Ruzkowski, and the fellows presenting for Parkview are Jaclyn Fackler and Benjamin Pottebaum. Dr. Yan from the University of Colorado School of Medicine will now present the position, the window is open.
Hi, everyone. My name is Kathleen Yan, and I'm a second-year GI fellow at University of Colorado. I will be presenting the pro-beta blocker side. I have no disclosures other than my unbridled enthusiasm for beta blockers. Let's first start off with why beta blockers work. Here we see the progression through the different stages of cirrhosis, starting with early cirrhosis, then you progress to decompensated cirrhosis, and then finally end-stage cirrhosis. And throughout disease progression, you see that you get an increase in the renin, angiotensin, and aldosterone system activity, which is driven by increased intrahepatic resistance and also splanchnic vasodilation. This results in an increase in cardiac output, which drives portal hypertension. In the late stage of cirrhosis, you also get an increase in gut bacterial translocation. And beta blockers really work to improve survival and by reducing variceal bleeding by targeting this mechanism, and also by reducing gut bacterial translocation. Now, my opponents are going to make the argument that based off one study by Surstay et al., that the window for beta blocker use in this patient is closed. But I'm going to show you that, in fact, it is wide open. So let's just be clear. Non-selective beta blockers save lives. They are indicated for both the primary and secondary prophylaxis of variceal bleeding. They really work because they target the pathophysiology of portal hypertension. So they get at the root cause of the problem. And as a result, many, many studies have shown that they improve survival in cirrhosis, period. So would you not give our patient a life-saving treatment just because of one poorly done study by Surstay et al.? Well, let's look at the evidence. Here's a study by Boston et al., which is data taken from randomized controlled trials of Zadovaptan, showing that in patients with ascites, there is no difference in mortality with beta blocker use. As you can see here, in both the cases of refractory ascites as well as diuretic responsive ascites. In the same study, looking at different subgroups of patients, again, you see that across whether you have patients with refractory ascites or history of previous SBP and a whole range of MAFs also, there's really no significant difference in mortality. And here is another study looking at varying degrees of ascites. We see that the use of a beta blocker, carvedilol in this case, did not increase mortality at all. And if anything, the hazard ratios less than 1 are in favor of carvedilol use in both moderate and severe ascites. And just in case that wasn't enough, here's one more study by Buta et al. Looking at survival again. And so we see that the use of beta blockers, there is no significant difference on survival between these two groups. And here is yet another study by Lighthead et al. In the setting, again, patients with ascites. We see that on a transplant waitlist, we see that non-selective beta blocker use was actually associated with a lower risk of death, as seen here in the solid line compared to the dashed line. And this is true in both patients with refractory ascites as well as non-refractory ascites. So that was evidence for patients with refractory ascites, such as our patient. Now let's look at survival in spontaneous bacterial peritonitis, or SBP, which is who are among our sickest of patients. So in the study by Turgast et al., we see that those patients who were taking a beta blocker in the green line had better survival compared to those who were not. And again, in this study by Bang et al., which was a Danish cohort registry study, it was actually well conducted, as you can see with their propensity score match analysis. And they see that the hazard ratio is 0.4, which is very much in favor of beta blockers. And not only that, but actually in this study, we see that the use of beta blockers actually decreases your risk of getting infections, including SBP, in the first place. So with this data, we see that patients who were not taking beta blockers actually have higher odds of infection. For example, here, they had 4.2 times higher odds of getting spontaneous bacterial peritonitis compared to patients who were taking a beta blocker. And then here's another group of extremely ill patients, those with acute on chronic liver failure, or ACLF, and we see in these two separate studies, patients who were taking a beta blocker, as shown here in the green lines, had much better survival compared to those who were not. And also in general, severely decompensated cirrhosis, we see that beta blocker use was associated with a lower risk of death, as well as hepatorenal syndrome and peritonitis. So with all of this overwhelming evidence for beta blocker use, what was up with that Surstay study? Because they were really the only ones that found that beta blockers were associated with worse survival in patients with refractory ascites. Well, I'm sure my opponents will bring up the flaws of this study, but just in case, this was a non-randomized study with significant cohort differences in the beta blocker group. For example, higher bilirubin levels, more patients with child C cirrhosis, and these factors were not controlled for in a multivariate model, which is a major flaw. Additionally, this study had really high doses of propranolol, 160 milligrams a day, which is insane, and you would never actually do that. Additionally, mortality in this study was actually mostly due to hepatocellular cancer progression, which isn't even related to beta blocker use in the first place. And so just to sum up all of the studies we have discussed today, we see that we had a really good mix of retrospective and prospective data, several of which were multi-center trials. And in total, we had data from a total of 8,774 patients. Wow. So in summary, we want to keep the window open, especially for this patient. Non-selective beta blocker use should not be avoided in patients with refractory ascites and SBP, including our patient. And these are consistent with the guidelines as published by Dr. Guadalupe Garcia-Tao in the AASLD practice guidelines. And she's actually here today. And in this picture, you can see that she's shown here with yours truly. Thank you so much for your time. And here are my references.
Thank you, Dr. Yan. So on to our next presentation. Dr. Jaclyn Fackler from Parkview will now provide the position that the window is closed.
Our patient is a 52-year-old insulin-dependent diabetic with decompensated cirrhosis as evidenced by refractory ascites requiring serial paracentesis, renal impairment with a creatinine of 1.2, a blood pressure of 110/50, demonstrating systemic vasodilation, and a history of esophageal varices with improvement post-endoscopic variceal ligation. Her MELD sodium is 20. In advanced cirrhotic patients, there's progressive splanchnic vasodilation that causes a decrease in systemic vascular resistance. Initially, there's a compensatory increase in cardiac output that works to maintain mean arterial pressure. However, when cardiac output cannot further compensate for vasodilation due to progression of disease or non-selective beta blocker use, severe circulatory dysfunction with hypotension ensues, leading to refractory ascites, hyponatremia, and eventually decreased renal perfusion and hepatorenal syndrome. Given that non-selective beta blockade interferes with the potential for increase in cardiac output, their use can lower the threshold for clinically significant renal hypoperfusion. The effects of beta-1 blockade include reduced heart rate and cardiac output. Effects of beta-2 blockade include splanchnic vasoconstriction with a concomitant decrease in portal collateral blood flow with a mild increase in peripheral hepatic resistance. In the case of carvedilol, an anti-alpha-1 effect can additionally result in intrahepatic vasodilation and further decreases in portal pressure. This was demonstrated in a group of patients with refractory ascites on non-selective beta blockers at the time of paracentesis with measurements in heart rate, mean arterial pressure, and plasma renin concentrations. Paracentesis-induced circulatory dysfunction, as evidenced by a 50% or greater rise in plasma renin concentration, was demonstrated in 80% of the studied patients while on beta blockade. After non-selective beta blockade was discontinued in these same patients, only one patient went on to develop paracentesis-induced circulatory dysfunction after subsequent paracentesis. On a clinical level, the deleterious effects of non-selective beta blockade on renal function were observed in a population of 205 with matched control subjects. Among patients with pre-existing ascites, the use of non-selective beta blockade was associated with threefold higher incidence of acute kidney injury. The use of non-selective beta blockers in these decompensated patients has been demonstrated to have a statistically significant negative impact on mortality. In those patients not treated with non-selective beta blockade, the 1-year probability of survival was 64%, compared to 19% in patients on non-selective beta blocker therapy. This pattern held on follow-up at 2 years with a 45% survival rate in patients not on non-selective beta blockers, compared to 9% of those on therapy. Furthermore, in patients undergoing transplant evaluation with right heart catheterization as part of standard workup, it was demonstrated that waitlist mortality was higher in patients with refractory ascites. Additionally, those receiving non-selective beta blocker therapy with a left ventricular stroke volume index less than 64 were at higher waitlist mortality than those patients not receiving beta blockers. Mortality risk was again demonstrated in 171 Child-Pugh B and C patients, including those with MELD scores greater than or equal to 18 treated with non-selective beta blockers. This disparity was most pronounced in Child-Pugh C and high MELD patients after 6 months, but again, persisted to 2 years. What about quality of life? In an evaluation of the predicted preferences of physicians and patients, it was found that 64% of patients and 57% of physicians preferred endoscopic variceal ligation to beta blocker therapy. The most cited reasons for this preference were risks of shortness of breath, hypotension, and fatigue. There's good reason for this concern. Up to 15% of patients will have a relative or absolute contraindication, such as our patient with diabetes mellitus with potential for hypoglycemia, COPD, peripheral arterial disease, and AV block. An additional 15% of patients will develop adverse effects leading to discontinuation of therapy, typically orthostasis, shortness of breath, and fatigue, among others, which can considerably limit quality of life. In some cases, the patient may have to have additional medications prescribed to combat these adverse effects, which may in turn lead to further adverse effects. Let's talk money. A simulation of standard clinical practice assessed patients found to have moderate to large varices at screening. Ligation was found to be more effective, although somewhat more expensive than beta blockade, with an incremental cost compared to beta blocker therapy of $25,548 per quality adjusted life year, well below the accepted range of $50,000 to $100,000 for quality adjusted life year. A subsequent US study demonstrated a lower estimated cost while comparing endoscopic variceal ligation to beta blockers. There are additional pitfalls of non-selective beta blocker therapy. Patients on non-selective beta blockers require close monitoring, including continual follow-up of hemodynamics, renal function, and hepatic function, as these can alter bioavailability of this class of medication. Additional concerns include hyponatremia and high baseline risk for spontaneous bacterial peritonitis and other infections. Furthermore, there are no non-invasive measures to monitor hepatic venous pressure gradient response, so non-selective beta blockers are titrated to a maximally tolerated dose, placing these patients at greater risk for serious injury and respiratory compromise. While use of non-selective beta blockade may have benefits in a subset of cirrhotic patients, our patient who is severely decompensated with signs of circulatory dysfunction, including low MAP, refractory ascites, and renal insufficiency, would not fall into this category. Additionally, she's been successfully treated with endoscopic variceal ligation with demonstrated improvement and would require continual monitoring for development of worsening circulatory compromise and infection were she to be placed on non-selective beta blockade. Given her insulin-dependent diabetes, she's at additional risk for hypoglycemic unawareness, and thus non-selective beta blockade is a relative contraindication.
Thank you, Dr. Fackler. Thank you to the timekeeper to keeping the debate even. Next up, we're going to have Dr. John Rice from the University of Colorado School of Medicine, who will now respond and rebut the Parkview Medical Center position.
Good evening, everyone. While I commend my competitors on their efforts today, there is in fact only one correct answer to today's debate. Non-selective beta blockers save lives, and they are safe in patients with cirrhosis and ascites. The data is clear. Non-selective beta blockers reduce the risk of variceal hemorrhage by 10% for primary prophylaxis, and this goes up to 21% for secondary prophylaxis when compared to placebo. This benefit persists even in patients with decompensated cirrhosis who are at a high risk of bleeding, just like our patient. With the risk of death from a variceal bleed as high as 20% at 6 weeks, providers should be doing everything they can to prevent these sentinel events. This data and others have led the ASLD guidelines to state that pharmacologic therapy is the cornerstone of combination therapy for secondary prophylaxis. However, as explained by Dr. Yan, the benefits of non-selective beta blockers extend well beyond bleeding prophylaxis and have been shown to decrease the risk of clinical decompensation or liver-related death by half in some patients. This survival benefit extends to our sickest patients, specifically patients with acute on chronic liver failure or spontaneous bacterial peritonitis, via reduced gut permeability, reduced bacterial translocation, and reduced systemic inflammation. Given all of these benefits, the British Association for the Study of the Liver recent guidelines on ascites management supported the use of non-selective beta blockers when indicated in patients with refractory ascites. However, despite all the evidence against them, my opponents have argued that the presence of refractory ascites is contraindication to starting non-selective beta blockers. The center of the argument is the CERTSI study, which first brought about this idea. However, as Dr. Yan explained it, this study is flawed and missed the mark. In fact, there have been numerous subsequent studies, including 5 meta-analyses that have shown either similar or superior survival in patients with refractory ascites receiving non-selective beta blockers. And in a recent large cohort study by Turgast and colleagues, patients with decompensated cirrhosis and ascites, non-selective beta blocker treatment was associated with higher transplant-free survival with a hazard ratio of 0.62. My competitors today have argued that our patients' low blood pressure should prevent beta blocker initiation. However, according to the Baveno 6 consensus, which is produced by international leaders in the field, beta blockers should only be avoided or reduced in patients with refractory ascites when systolic blood pressure is under 90, their sodium is less than 130, or they have an acute kidney injury, none of which are present in our patient. A recent study showed that the benefits of beta blockers continues down to a MAP of 65 when tolerated. Moreover, the benefits of beta blockers can be seen even at low doses, which are usually well tolerated in patients with refractory ascites when monitored closely. They've also argued that non-selective beta blockers increase the risk of renal dysfunction. However, in a recent study by Shiner and colleagues, non-selective beta blockers were not associated with worsening kidney function or incidence of AKI in patients with ascites, MAP of less than 90, or baseline creatinine greater than the upper limit of normal. While a recent study by Tellez showed that non-selective beta blockers do increase the likelihood of lowering renal perfusion pressure below the critical threshold as explained by my colleagues, thereby reducing renal function, this difference was mostly seen in patients with a MAP under 65, which is an already established cutoff for stopping or reducing beta blockers. They've also argued that beta blockers increase the risk for post-paracentesis circulatory dysfunction. However, in this study by CERTSI that demonstrated this, they were using inappropriately high beta blocker doses, with 7 of the 10 patients receiving 160 milligrams of propranolol per day. In subsequent studies, those doses have been shown to have deleterious effects, and who even here uses those doses that high anymore? It's unclear if this effect would persist at lower, more appropriate doses. They've also argued that bandy monotherapy is an effective secondary prophylaxis. However, there have been 6 meta-analyses that have shown the combination therapy significantly decreases the rate of variceal bleed when compared to endoscopic therapy alone. Moreover, in a meta-analysis by Albinos et al., combination therapy significantly reduced the rate of overall mortality compared to endoscopic therapy alone, especially for child's B and C patients, just like our patient. In conclusion, there are abundant evidence-based benefits to non-selective beta blockers in patients with cirrhosis and ascites, including reduced risks of bleeding, hepatic decompensation, and most importantly, death. Since the CERTSI's initial paper, there has been a significant medical reversal through numerous high-quality studies presented today. Fortunately, our society guidelines now reflect the benefits of non-selective beta blockers, thereby encouraging more patients to prescribe these life-saving medications. While there is risk of inappropriate prescribing of beta blockers, this can always be avoided with starting at a low dose, titrating slowly, and monitoring closely. In fact, you only need to treat 20 cirrhotic patients with refractory ascites with non-selective beta blockers to prevent 2 variceal bleeds and 1 patient from dying.
Thank you, Dr. Rice. Obviously, a lot of things you wanted to rebut. Well, our last debater will be Dr. Benjamin Pottebaum, from Parkview, who will now rebut the University of Colorado School of Medicine position and rebuttal. Timekeeper ready? Benjamin, you may begin.
Okay, thank you guys for having us, and thank you to the opposing team. What our opposing team, I think, fails to display is that the use of beta blockade is used for prophylaxis or prevention. Now, if you take into consideration the fact that our patient alone had evidence of jaundice with her bilirubin of 4.1, encephalopathy, as she is on, or had a history of that, and is on lactulose and rifaximin. She's had recurrent ascites and a variceal hemorrhage history. Her life expectancy, or median life survival, is around 1.6 years. In this patient, using a beta blockade in her is very risky. Most of the studies that the pro team has argued typically had patients that were in the MELD and sodium scores in their teens, whereas our patient is at a MELD score of 20. Now, in addition, she had evidence of a low MAP. 110/50 was her blood pressure, giving her a MAP of 70. With that, most of the studies that were presented from the pro team showed that anything less than 70 was typically pretty detrimental to the patients. In addition, this patient also has done very well with banding in the past, in that she's now down to grade 1 varices from her previous issues with variceal bleeding and hemorrhage. Other thoughts about the patient, and specifically in this patient, include the use of her insulin, as Dr. Fackler made mention. Patients that are on beta blockade therapy have decreased hypoglycemia awareness, which could lead to further issues and mortality and morbidity for the patient. As well as increased burden on the whole medical field and hospitalizations. One thing additionally we would like to discuss is that her creatinine is 1.2, and we've been talking about using this as a way to decrease overall blood pressure, but all organ systems are essentially affected by this, including the kidneys. And because of that, if you were to put her on any type of beta blockade, and the pro team made mention to multiple studies that the beta blockade levels were at high dosages, even with the minimal dosages of any beta blocker, you would have likely decrease in blood pressure and overall perfusion to kidneys. So no matter what their argument is about how high a dosage the beta blockade is, I believe any dosage would really cause issues for this patient. I believe that there are good evidence to support beta blockade in general for most patients, but I think this is why medicine is a special field, and for one that we should take each patient individually and consider it. And in this patient in particular, I believe that we should hold off on any beta blockade. Thank you.
Thank you, Dr. Pottebaum. Thank you to all the debaters. Right now, we're going to begin the Q&A. I'd like to welcome our judges, Dr. Boster, Goff, and Sundaram, and both of our teams. Dr. Goff.
Sure. Well, I would want to ask initially if any of the presenters would consider looking at this patient who's a bit on the high risk side of whether they would use maybe an echocardiogram to further evaluate this patient, because portal pulmonary hypertension and cardiomyopathy, which could exist in this patient, would have some impact on whether you chose to do use the non-selective beta blockers.
Let's go with, I'm going to go in reverse. Let's go with Parkview. You can answer first.
I think I don't know if it necessarily would change my opinion on the matter about using a beta blockade. I just feel like it would give you more information, and it definitely would evaluate, the pulmonary system as well as cardiac system. And I think it would actually probably point me into further not using a beta blockade, given the fact that she's already borderline on so many other organ systems.
University of Colorado.
So I think echo can help in this case, because I think to further argument, it's actually cardiac output and not the presence of ascites that's more important for the initiation or cessation of beta blockers. And one of the studies they presented actually that looked at a unique feature of left ventricular systolic function showed that beta blockers had no impact unless there was cardiac dysfunction. So it's actually not the presence of ascites or not, it's more the cardiac output that's important. And I think that's where this field is going right now, is understanding these people's physiology, specifically their cardiac physiology, not just the ascites, which is a surrogate marker.
Thank you. Dr. Sundaram?
Thank you to both teams for two very compelling arguments. Both teams have been very focused on decompensated cirrhosis, specifically around ascites. But if your patient had either or portal hypertensive gastropathy or gastric varices, how would your decision-making change?
So I'm going to reverse the answers here. I'll go with the University of Colorado first.
Well, as we all know, there are different types of gastric varices, and so the management of that may or may not involve an interventional radiology procedure, though that area of whether beta blockers work in gastric varices is obviously, there's a lot of research that needs to be done to definitively clarify the issue.
And Parkview.
I'll speak up on this one. Kind of speaking to different types of gastric varices, as we know, there are certain types that you can treat similarly to esophageal varices, potentially with some intervention with the GI team versus interventional radiology. I don't know as it would necessarily change our position on beta blockade, given that we can manage some of those similarly. I guess we'd need potentially a little more information regarding the gastric varices.
Thank you. Dr. Booster.
Yeah, I'd like to congratulate both teams on two well-stated arguments as well. And I'm curious as to, for both teams, how your decision to start a non-selective beta blocker in a patient with ascites might be affected by the COVID pandemic. And in Colorado recently, a halt on elective procedures, which might make access to endoscopic band ligation, might make access to that reduced or limited.
Yeah, so I think it kind of goes back to the line that COVID has definitely brought on some challenging times. I think for the standpoint of halting elective procedures, that is going to be a risk. I would say that we are still fortunately doing some work with paracentesis and so forth. So these patients can still get their TAPs done, but it may lead you to treat things that you would normally treat endoscopically with more medications, which is definitely something that I think, like I said, you have to kind of go by a case-by-case basis. History of variceal bleeding, history of EGDs, how many bands, et cetera. So I think you'd kind of have to take the whole clinical picture and evaluate other risk factors. For instance, if they have like cardiac like respiratory compromise, if they're getting shortness of breath from that, and other risk factors like sepsis or infection.
Great. And so to answer the last question, I'll turn it to the University of Colorado. If we could try to keep it relatively short, that would be great.
So I think it's a great question, and I know all of us are backlogged right now and trying to catch up on procedures. And a lot of the benefits from endoscopy ultimately come from serial endoscopy in these patients requiring eradication of the varices. So I think unless you can commit to getting these patients in an appropriate amount of time, I think you'd put them at potentially more risk if you're spacing these out. So I think a beta blocker, either as monotherapy or in addition to the variceal ligation, could potentially help reduce, the risk in these patients as we have to space these out in the real times that we live in right now.
Thank you very much. So I want to congratulate all the teams. I think at this time, the judges are going to recuse themselves and make some decisions. But before we conclude this, I'd like to ask the audience to answer a quick follow-up poll. Based on the presentations, have you changed your mind about whether or not the clinical benefit of beta blockade outweighs the risks and should be prescribed in cirrhotic patients with ascites? In other words, would you prescribe them? Yes, or would you not? No. Well, the shift has been from yes to no. Very interesting. All right. So while everyone's out debating, once again, I'd like to express our gratitude to our national sponsors for their support of tonight's event, our national gold sponsors, AbbVie and Eisai, our national silver sponsor, Salix, and our national bronze sponsors, Alexion, Mallinckrodt, and Pfizer. I'll leave this up for a second. Now, here's the time where I ask you to open up the pocketbook. Don't forget, there's still time to donate. We're truly grateful to our audience members who took a moment to donate. And if everyone could look in the Q&A box, you'll find the link to make your donation this evening. While you're making your donation and we begin to make closing comments, all of our mentors and debaters will join us for the final comments on the evening and the announcements of the winning teams. And I'm waiting for the envelope, actually. I'd like to congratulate all the teams on an outstanding job, thank their mentors for their expert guidance, the judges for thoughtful questions, the ALF tech team, which has done a fabulous job. And I hope this is the first of many such debates in the coming years. And this will be an annual event with more individuals with this. So I'd also like to let the audience know that the ALF is hosting academic debates across the US. Please register for these important virtual programs, help us promote them in the healthcare community. You can see they include Pennsylvania, the greater DC area, Michigan, and maybe next year we'll have more teams. Also, please remember to visit the ALF website, recommend it to your friends, family, colleagues, and most importantly, patients. As a reminder, the ALF has many resources for the liver patient, including a helpline, exceptional educational programs, both for families and for healthcare professionals. We encourage you to visit the links on the site to explore all that we have to offer. And please encourage your patients to come visit us too. ALF helps connect the liver community through Cuisine for a Cause, liver walks, and educational program. We'll have more information on the 2022 programs coming shortly. Remember to use our social media and all of the links that are shown on this page. So, all of our teams have performed exceptionally well this evening, and I'd like to announce the winner. The winner of the first Rocky Mountain academic debate is the University of Colorado. Congratulations to the team. Congratulations to Parkview. I think we gave you a position with a lot fewer references to go. It's interesting that the poll of the audience, though, flipped to no for beta blockade in this particular patient. So thank you for sharing your hours of research, elevating our understanding on this controversial and really clinically important topic and its benefits and drawbacks, devoting your time to patient outcomes. In our estimation, both teams are winners, and the real winners are the community. So I hope to see you again next year, and stay safe and healthy. Have a great night.